It's a real pleasure for me to be here. Good afternoon, everybody. So I would like to tell you, just as Dan mentioned, this new clinical diagnostic test we have recently brought from the research laboratory into the clinical setting. And it's really an exciting time for us and to make this into clinical practice and start to contribute to the diagnosis and prognosis of cancer in particular. So today's talk, after today's talk, I hope you'll be able to achieve these learning objectives to describe the resolution of chromosome genomic array testing in comparison with those of G-banding cytogenetics and FISH in terms of the resolution, and list 3 advantages of genomic array testing. You'll be able to know the definition of copy-neutral loss of heterozygosity and appreciate its diagnostic and prognostic value in neoplasia. Finally, to be able to describe at least one strategy to distinguish acquired clonal aberration from those constitutional changes. So we use this term chromosome genomic array testing because the acronym CGAT encompasses the 4 building blocks of nucleic acid. But you must have heard a lot of other acronyms like the SNP array CGH or array CGH, and here I think people refer to it as cytogenomics as well. Regardless, they are very similar in nature. So I would like to use a few case vignettes to help you learn these learning objectives and to illustrate the clinical utility of this testing. And at the end of my talk, I will also introduce briefly of some of the research updates we have in my research lab regarding disseminated tumor cells in prostate cancer. So first case I would like to tell you about is a new diagnosis, newly diagnosed acute myeloid leukemia case. It is a 57-year-old female, and when we received the first sample, the flow cytometry analysis showed a 30% abnormal blasts in the peripheral blood. And the patient showed normal cytogenetics, 46XX female, and a normal AML FISH panel. Now, molecular testing also came back normal with no mutations in FLT3, NPM1, CEBPA, the normal suspects. So we performed array testing on the blood of this specimen, and lo and behold, we found a 1.5 megabase deletion of the proximal long arm of chromosome 17, and it is the only abnormality. It actually encompasses the NF1 gene. And here's the array testing result depicted on this slide. So for those of you who are new to the array field, I wanted to just briefly orient you as to how to read this. So basically, there are 3 panels here, top, middle, and the bottom. So the top panel is the log2, representing the log2 ratio of the fluorescent intensity signals. So each dot, blue dot, actually represents a genetic locus primed by a probe. So then when you, this line here, the middle, represents the normal 2 copy positions. And whatever is below that shows the deletion, and whatever is above that shows the gain, so genomic imbalance. The middle panel is a allelic track, and I will tell you more about it later. And the bottom panel is the smoothed signal of the log2 ratio, so essentially the same as the top panel, but it gives you a slightly better and easier view of the abnormalities. So here you see the 1.5 megabase submicroscopic deletion of the NF1 on 17q. So how is this performed? We, in our laboratory, after various validations and extensive platform comparison, we settled down on this Affymetrix Cytoscan HD platform, which includes 2.5 million total markers. And among these, there are 750,000 genotypable SNP markers, single nucleotide polymorphism markers, and 1.7 million nonpolymorphic probes. So this is a very high density coverage of the entire genome, and so in terms of the almost 20,000 ref-seq genes, the coverage at those specific gene regions are 1 marker per 3 kb. So I like this illustration of a picket fence. So the SNP probes are just like those pointed large poles here. And so these are relatively sparse in the genome compared to the other markers, but still they provide more information. And whereas those shorter poles would represent the non-SNP, non-polymorphic markers, which will allow denser coverage of the genome and gives you very clean signals. So the advantage of balanced array content with both the SNP and the non-polymorphic markers is very well illustrated by this region of the genome, where we have the Fanconi anemia gene, FANCB gene shown here, and it's like about for this 105 kb region where encompasses the FANCB gene. If you use only the SNP markers to form the array, like the previous generations of the Illumina and AFI and other common ones, you will not see any of the FANCB gene. There's no coverage there. But if you use a combination of the SNP marker and the non-polymorphic markers, you will have 58 markers there, giving you a high confidence in terms of evaluating this genomic region. So the advantages of genomic array testing, as shown in the first case, is that definitely it has enhanced diagnostic yield. So we're able to detect copy number aberrations, either gain or loss, of like 100 kb in size with very high confidence. So compared with, if I put this in context, compared with the traditional G-banding cytogenetics, where each band, even at a higher resolution, is approximately 5 megabases and larger. So if like for most of the cancer metaphases, your banding level is at 400 band level, for those of you who are familiar with that, that 400 band level, each band would be 10 megabases or even larger. So with the array, you have a much better, higher resolution. And for FISH testing, you can typically, the commercial probes that we use in the clinical laboratories are 500 kb in size. So typically, you'll be able to detect any genetic aberrations greater than 200 kb in size. Any aberrations smaller than that will still result in hybridization, so you won't be able to see the deletion or changes. So here's, and also in addition, because we do not need metaphases for array genomic testing, so therefore it really opens a door for the solid tumor testing, which previously was not able to be done by cytogenetics. And then in terms of FISH, because we understand when we do FISH testing, we have to know your testing target to start with. Otherwise, you don't know which FISH probe to use. Whereas the array testing allows unbiased whole genome coverage, and then which allows you to find the actual genomic target that is imbalanced. Okay, so then this case also helped us to tell us that potentially the results can actually guide therapy. The reason is, in this case, when we identify the NF1 gene deletion, this is a gene that encodes the neurofibromin protein, which negatively regulates RAS signaling proteins by alteration of the adenosine triphosphate hydrolysis. And the clinical geneticists will tell you that patients with constitutional NF1 mutations are predisposed to development of juvenile myeloid neoplasms, including juvenile myelomonocytic leukemia, myelodysplasia, and acute myeloid leukemia. Now, there was previously an in vitro study performed that demonstrated in NF1 mutated myoblasts using rapamycin can actually induce apoptosis through the PI3 kinase AKT-mTOR pathway. So it is proposed that patients with NF1 mutated AML might benefit from inhibition of mammalian target of rapamycin. And rapamycin is an FDA approved drug that is currently in use clinically at SCCA for transplant patients. It is used to prevent GVHD. But it has not been used directly to treat AML patients. So clinical trial for the off-label use of this medication still need to be carried out. So actually, I'm working with Dr. Eli Esty at SCC and trying to design some clinical trial protocols to test that out. So the second case I would like to tell you about is also an AML case. This is not a newly diagnosed AML, it's a refractory AML. So a 63-year-old male who had been treated by various type of induction chemotherapy still didn't respond and didn't achieve remission. And again, the cytogenetics was normal and no FISH was done. And when the patient, this sample arrived out at our laboratory at that time, flow results showed about 80% of abnormal myeloid blasts. And the path morphology was also consistent with the diagnosis of AML. Here's what we saw on the array testing. So here you see on the proximal long arm of chromosome 9, so you will see several segmental deletions. So it's a complex, multiple deletions over there of various size. In addition, on chromosome 11, we were able to see both the short and the long arm of chromosome 11 showed mosaic copy-neutral loss of heterozygosity, which I'll tell you a little bit more about that in a second. And we also see on the long arm of chromosome 11, this common, well-known gene, multiple lineage leukemia gene, MLL gene, showed a very sharp peak of gain of 33 kb gain. So suggesting a partial tandem duplication of the MLL gene, which has been reported in the literature associated with AML with poor prognosis. So how, I mentioned before, I wanted to tell you how was copy-neutral loss of heterozygosity was detected. So I mentioned before there are nonpolymorphic probes and SNP probes are used in the array platform. So each probe is about 25 bases in length. And so in the chart, we're actually, each probe is labeled with fluorescent signals. So we're measuring the fluorescent intensity. And the fluorescent signal intensity is actually proportional to the copy number of that specific genomic target. So in a normal situation, you have 2 copies. And so in non-polymorphic markers will show you the fluorescent intensity corresponding to the 2 copies without able to distinguish one allele from the other. So if you lose 1 copy, you just see a single copy, so a drop in the fluorescent intensity. And if you have a gain, you see an increase in the fluorescent intensity. Whereas if you use looking at the SNP markers, and when you have 2 copies, you actually have a combination of allele A and allele B at any given SNP marker location. So if you have loss, like a single copy loss of the allele, then you will end up with 1 allele only, and in addition to the drop of the fluorescent intensity. So essentially you will have a loss of heterozygosity associated with a deletion in this case. Now, so the allelic track, which I showed you earlier but didn't mention much about, this actually is a very interesting tool that allows us to gain much more information based on these SNP targets, SNP probes. So it actually looks at the frequency of A minus B allele and the difference between the 2. And so in normal situation, you will be able to see the 3-track kind of pattern, allelic pattern. And if you have deletion, you will be losing the heterozygous track and see just 2 the homozygous track alone. And here you see the homozygous deletion. And if you have gain, this is the pattern you see, and copy-neutral loss of heterozygosity, or mosaic gain and mosaic loss. I won't go into too much detail of this, except to tell you, here is the copy-neutral loss of heterozygosity, which is very helpful for us and which is not detectable by any other methods so far. So here, detection of, how do we detect the copy-neutral loss of heterozygosity? So as we know, in our genome, each chromosome have 2 alleles. One is inherited from the mom and one is inherited from the dad. So when you look at the genomic alleles at any given locus, there are 3 possible combinations. So you would be either AA or AB or BB. So when you have multiple, when you're ascertaining multiple loci together, and these will look like, when you have millions and hundreds and thousands of probes together, they'll look like that, the 3 track. That's how a normal pattern of the allelic track is obtained. Now, when you, in some circumstances, when one of the allele is, like specifically in cancer, is deleted or mutated or rearranged or whatsoever, there's some kind of abnormalities there, and if it so happened the other allele got lost, either because of segmental deletion or because of a loss for random loss or whatever, and then there's mitotic recombination or due to any other mechanisms of subsequent replacement of the lost segment through gene conversion, or because of mitotic non-disjunction, region trisomy status, and then loss of the normal copy, you will end up with 2 copies of the same parental allele. So that is called uniparental disomy. So in this case, you will see a allelic track pattern looking like that. So it does not change the copy number, however, you have a loss of heterozygosity. So that's why it's also called copy neutral loss of heterozygosity. So because of this combination of the approach, we'll be able to ascertain very complex chromosome rearrangement in various disorders. This is an example of a very complex chromosome 6 rearrangement in a case of AML. And here's another example of a complex short arm chromosome 12 rearrangement in a mantle cell lymphoma case. Here's a very large gain amplification of the terminal 12p. So this, coming back to the second case I introduced earlier, so we saw this both the short arm and long arm copy neutral loss of heterozygosity accompanied by the MLL gene partial tandem duplication. So how do we know it is actually real? It is actually not constitutional because we heard of so many copy number variations in the just normal genome, right? With this high resolution, unprecedented high resolution technology, you are able to pick up a lot of normal variation in the genome. So how do we know this is, in the cancer field, it's really critical to distinguish acquired clonal abnormalities related to the cancer to distinguish that from a constitutional abnormality. So in this case, we happen to have a sample from a year ago, which we processed during our validation stage for the array analysis. And there was at the time, we tried using magnetic bead separation method to separate the CD3 fraction, which representing the T cells in myeloid disorders and which are typically normal, representing the constitutional fraction, and the CD3 negative fraction was analyzed here, shown here. And at that time, you also have the MLL peak, which is smaller at that time, and you have a almost 100% copy neutral loss of heterozygosity at the short arm. But notice there's no copy neutral loss of heterozygosity at that time on the long arm of chromosome 11. And compared with the constitutional fraction, the CD3 positive fraction, you don't see any of these abnormalities, 11p CNLH or 11q or the MLL partial tandem duplication. So this brings me to the point, the learning point that we can learn from this case, that we should be able to distinguish acquired versus constitutional abnormalities using various approaches, which I will elaborate a little bit in the next slide. And you can also appreciate the clonal evolution associated with the disease progression when we are comparing earlier diagnostic samples with a more recent one, later stage one. And then these also provide prognostic risk assessment. So there are several different ways of the strategies to distinguish somatic versus constitutional abnormalities. So obvious one is using normal control references. Currently, there are many different databases to exclude copy number variations that are known to happen in normal people. And the approach that we use in the clinic, I think it's most useful, is the paired sample testing approach. So there are I'm going to introduce 3 different ways to do the paired sample testing. The ideal scenario strategy is really to compare the diagnostic with the remission sample. So, but it's very hard to get diagnostic and remission pair, and sometimes the time frame, like patients don't come back to you and you only get 1 sample, and sometimes there's significant time interval between the 2 sampling. So that's hard. So then the case that I showed you just now, the case 2, it basically illustrates the paired cell fraction methods. So you could use either flow sorting or magnetic bead separation method to enrich the fraction that you want to use. And but of course, that process itself needs to be clinically validated in order to be used for clinical testing. And then the caveat of this approach is that sometimes the normal control fraction may not totally be normal, because we have heard of some patients in the T cell population could still see myeloid clonal abnormalities in myeloid disorders. So that's the caveat. Now, the other way is to look at the longitudinal diagnostic pair, which is also illustrated by this case I just presented. So you can see the changes in magnitude to understand this as a actually true acquired abnormality. But sometimes these changes are not necessarily discernible. So by the way, the cell enrichment method can also give you a ability to detect very low levels of abnormality. Here's just an example with collaboration of Dr. Heimfeld in the cell therapy lab at CCA. We were able to enrich the CD138 positive plasma cells from a multiple myeloma patient, and it allows the detection of very low level of the abnormality. So the flow and FISH were both showing less than 5% of the abnormal cell population. However, when we enrich these, you can see unequivocally a lot of gains and losses of chromosomes. In this case, I'm showing you the whole genome. So on the left side is chromosome 1 and separated by lines, and 1, 2, 3, 4 according to chromosomal order, and all the way to the X and the Y on the right-hand side. And so you also can not only see the copy number abnormalities, and the lower panel also shows you the copy neutral loss of heterozygosity of a chromosome. So coming back to that case, it also illustrates the prognostic impact using the array testing. So I already mentioned the 2 cases of AML with normal cytogenetics. So this paper published back in 2011 on Journal of Clinical Oncology demonstrated that array-detected abnormalities in AML can actually definitely have adverse prognostic impact for patients with normal cytogenetics. So you have this yellow line showing patients without any array-detected abnormality, and the blue lines showing the patients with array-detected abnormalities. The overall survival was shown on the left, and the event-free survival on the right-hand side. So the survival of patients are definitely much poor with array-detected abnormalities. And so they further showed that the array-detected abnormality, the adverse prognosis, is independent from the FLT3 mutations. So with the group of patients without FLT3 mutations shown on the upper panels, and the patients with FLT3 ITD on the lower panel, with additional array-detected abnormalities, these patients still do much poorer. So now how about the copy-neutral loss of heterozygosity? They also carry prognostic impact, demonstrated by this paper published in Leukemia. And so they are looking at the patients, AML patients with normal karyotype. They used the paired diagnostic remission sample approach, and they found that acquired copy number aberrations were detected in almost half of the cases, and most common are the 3P and 12P. And for acquired copy neutral loss of heterozygosity, they saw in about 12% of the patients, and in particular, the 13q, long arm of chromosome 13, copy neutral loss of heterozygosity is associated with an inferior outcome. And it's statistically significant. Whereas the 11p CNLOH showed a trend for possible better outcome. So coming back to this case, the initial sample a year ago showed this complete copy neutral loss of heterozygosity, and presumably was associated with a relatively good prognosis, whereas the MLL partial tandem repeat has been shown in the literature to be associated with a poor prognosis. Now, a year later, with a sample of actually diminishing of the short arm CNLOH and gaining in the MLL partial tandem repeat, along with the 11q, the appearance of the 11q CNLOH will tell you that it actually is progressing to the poorer prognosis kind of stage. So, and it is also reported by several papers in the literature that acquired uniparental disomy, or the copy neutral loss of heterozygosity, in myeloid disorders in both AML, shown in the black, and the MDS, shown in the red by the red text, is associated with actually specific gene mutations. So, for example, the 13q CNLOH is the most common one, and that's shown associated with the FLT3 mutations. That's a very common mutation with poor prognosis. And the 11p in AML is associated with the Wilms tumor gene, WT1 gene mutation, and in MDS it's associated with PAX6 gene mutation, and so on and so forth. So some of you working in that field will recognize some very important genes and well characterized and reported in the literature. So based on our own laboratory's experience, we saw improved diagnostic yield in both lymphoid and myeloid disorders. So in lymphoid disorders, we saw additional abnormalities detected by array in 75% of the cases, with CNLOH seen in about 25% of the patients. And the most frequent aberration is the 9p deletion encompassing this p16 tumor suppressor gene region. In myeloid disorders, the additional abnormality is seen in 53% with a CNLOH rate of about 20%. Now, among de novo AML patients with normal cytogenetics, we have the privilege of analyzing a very nice cohort of SWOG AML patients. So up to date, we've analyzed 117 such patients, and we saw aberrations detected in about 50%, consistent with the literature, and our CNLOH rate is 25%. And the most frequent CNLOH we saw was also 13q, and the less frequent followed by the 11p, 21q, 11q, and 2p. So the 4 to 5 cases out of the 32 cases that showed copy neutral loss of heterozygosity. So it's all very interesting, and so we're continuing to correlate that part of the data with outcome. So I have shown you, using those 2 cases, about the clinical utility of genomic array testing. There's definitely enhanced diagnostic yield, and there's a potential to guide therapy, and you will have the different strategies to distinguish acquired versus constitutional changes, and you'll be able to appreciate the clonal evolution associated with the disease progression, and to help with the prognosis, a prognostic risk assessment. But when I show this to the clinicians, they always ask you, well, this is all potential. Does it really change my management? How does it work for me? So I wanted to use this case to tell you that it really does change change patient management. So this is a case was kindly shared by Dr. Liu at the Baylor College of Medicine. It's a pediatric ALL case, and it is the patient was participating in the COG protocol called Children's Oncology Group. And so initially, this is what the chromosome looks like. So at first glance, there are so many chromosomes, it's a hyperdiploid clone, and we know a hyperdiploid clone is associated with very good prognosis. However, when the COG has a central cytogenetics review, so there are some very experienced cytogeneticists there, and they say, I don't think this is what it is. And there is a kind of near hypodiploid case of the pediatric ALL. Those patients those hypodiploid clone is actually associated with extremely poor prognosis. And when those hypodiploid clone gets duplicated, it'll mimic those hyperdiploid clone. So that experienced cytogeneticist said, I bet this is what it is. And so they went back to look at the using array analysis, and lo and behold, you see a lot of detection of the copy-neutral loss of heterozygosity in this stretch. So again, this is showing the whole genome from chromosome 1, 2, 3, 4, left to right. And so based on that, the karyotype was revised to it's actually a duplication of a near haploid clone, and it's duplicated, and then with addition of other chromosomes, and that's how you end up with a karyotype that looked like that. So in essence, this completely changed the prognosis and the risk assessment of the patient. Therefore, that patient was quickly switched off from the low-risk treatment protocol into the high-risk management protocol. So definitely it has changed the management of that patient. Now, we also have a patient of our own that we actually ascertained last week. Very interesting. So I'll show you this one. I think everybody in the audience will have no problem to recognize there is an extra copy of chromosome 14 here. But some of you who may be very good at pattern recognition, you might also be able to say, oh, look, this chromosome 21 is a little longer than usual, right? And that's exactly what the original diagnosis by another cytogenetic lab in Seattle came up with, plus 14 at 21. However, there's something else that's wrong in this one that was missed. Do you want to take a shot? Guess? Wild guess? So let me give you a hint. Here's another set from another cell. It's a set of chromosome 3 that's wrong. So here, these two chromosomes 3 at the end is a little shorter. It's harder, right? This needs a trained eye to look, a pair of trained eyes to look. So these are actually translocations between the long arm of chromosome 3 with 21 chromosome. So as we know, we revised the karyotype to 321 translocation along with 14 trisomy 14. So as we know, 321 translocation is associated, well characterized to be associated with AML, and it is a poor prognostic marker. So the previous the karyotype would define the patient classify the patient into the intermediate risk category. And now the patient is high risk, for treatment. So we further verify this by looking at FISH EVI translocation. EVI is a gene located on 3q26. And so the patient actually is EVI translocation. And again, when we looked at the array analysis, what did you see? Copy neutral loss of heterozygosity of the 3q. So not only do you have the translocation of the 3q and the 21 with the EVI rearrangement, but also you have the copy neutral loss of heterozygosity of the 3q potentially duplicating that rearranged 3q, rearranged EVI, so giving it even worse prognosis. So therefore, this patient definitely was put on the clinical trial protocols for managing high-risk patients and is considered for a transplant as well. So we can be pretty confident now to scratch out that potential guidance for therapy potential and say, yes, it does help the management of the patient. So with all the rosy pictures that I painted, there definitely are limitations as well for this genomic array testing. What are they? So I already mentioned before, it actually very low-level mosaicism or minimal residual diseases cannot be detected by the array testing. So during our validation stage, we kind of try to establish the detection limit, and we are being conservative and setting it up at 20%, but we can sometimes see 5% and 10% with pretty good reasonable confidence, depending on how clean the results are. Sometimes it's sample dependent. Now, but we are setting it at 20%. But I also showed you a figure previously with cell enrichment, you can push that limit down. Still, it's not meant to be used for minimal residual disease testing. And also, unlike cytogenetics, you're looking at each individual cells, you're looking at the lysed DNA, DNA obtained from lysed cells of many cells. So you're looking at the pooled cells. You won't be able to distinguish multiple clones from these individual cells. You also cannot detect truly balanced rearrangements or certain ploidy changes and point mutations or very small indel events. So, however, I wanted to mention half of what appear to be apparently balanced translocations are not really balanced. So oftentimes you will see very small submicroscopic deletions or gains associated at the break point of those balanced translocations. So in this case, it's again a case from the SWOG cohort, and we saw a small gain, like less than 100 kb, about 50 kb, small gain on 5q at the locus of NSD1, and another small gain on chromosome 11p at the NUP98 locus. And so we suspected, because we know that NUP98 and NSD1 fusion has been reported in AML, so we suspected this is a case of a cryptic 511 translocation. So we extracted RNA and ran RT-PCR, and yes, that is indeed a 511 translocation, which you cannot see on metaphases. And we're able to, because of the hint provided by the array testing, we're able to pick that up. So it's not a true balanced translocation. Now, talking about the MRD detection, so what we can tell from the diagnostic sample using the array is where exactly the genetic imbalance locus or loci are. So based on that, we can choose the specific FISH probe to target those regions and establish a baseline for future detection of minimal residual diseases. So this case we saw it's a chromosome 9 abnormality in a B-cell ALL cases. So you see both the 9p and the 9q deletion. And so if we focus on the 9p, you will see at this stretch of the relatively large deletion of 9p, heterozygous deletion, you also see a further dip over here of the 9p smaller segments, and that's suggesting homozygous deletion. So you can actually establish the baseline using the FISH probe targeting the P16 gene location. And so here's the red signal representing the P16 locus, and this green signal representing the centromere of chromosome 9 as a control. So normals, you would see the 2 signals, 2 copies, and heterozygous deletion, you see the 1 copy, and homozygous deletion, you see no red copies of P16. So indeed, that could be done. So as I mentioned earlier, because we do no longer require metaphases from these samples, so this really opens the door for solid tumor testing in addition to leukemia and lymphoma. So we tested a few renal cell carcinoma samples obtained from Dr. Vasella at the urology department. And here's again the whole genome view of the 2 samples where you will see abnormalities of chromosomes 3 and 5. And here in this case, it's the 1, P, and 3, 6, 9, and 14, etc. So you can definitely see, if it may be harder for you to see, it's the yellow smoothing line that we are looking at. Okay, so we can definitely detect the abnormalities in solid tumors using this strategy in a very confident way. And it is important to test for renal cell carcinoma, the genomics of renal cell carcinoma, because there have been publications reporting the prognostic value of those genomic changes. And so the UCLA group, Dr. Klatt, reported the survival impact of genomic chromosome aberrations in patients with or without specific chromosome abnormalities. And they showed that the 3p deletion is actually associated with better prognosis in renal cell carcinoma, whereas deletion of 4p, 9p, and 14q are associated with poorer prognosis. So it has many prognostic values in many different kinds of solid tumors, not only renal cell carcinoma. We have published a paper studying the human breast carcinoma and specifically looking at the comparison of ER positive versus ER negative breast cancer. And as most of you know, that ER negative breast cancer is a lot more aggressive than ER positive ones and has fewer treatment options as well. So we use the array approach to see what kind of genomic differences there are. So since this is a published study, so I won't dwell on it, except to mention like the way to look at this graph is the lower portion. This is like a probability, statistical probability summary chart. So the lower half of this summary figure is showing you specific genomic regions that are relatively gained in ER negative tumor or relatively lost in ER positive tumor, whereas the upper half are the genomic regions that are relatively lost in ER negative tumor. Okay, so yeah, so I won't go into too much detail of that. If you're interested, you can read this publication. So it tells us which kind of, using the genomics, it really gives a sense as to what might be the high-risk patient versus the low-risk patients. And so talking about using the chromosome genomic array testing for clinical practice, what is the best way to actually use it? So I would recommend using this test at diagnosis and relapse when the disease burden is high, because it's not meant to be used for detecting minimal residual diseases. And it should be tested in conjunction with G-banding cytogenetics, so whenever possible, so that you'll be able to ascertain truly balanced translocations as well, rearrangements. And it actually should replace the imbalanced FISH tests at the diagnostic setting, and do not blindly go in to do MDS FISH, multiple myeloma FISH. Rather, start with the array, test, find out the specific imbalance, then use the specific FISH targets, FISH probes targeting those regions to establish a baseline for future minimal residual disease follow-up. So the last few minutes, 5 minutes or so, I would like to introduce just briefly about some of the research work we are doing in our research lab. So our lab is interested in looking at using this approach of the genomic array testing to look at prostate cancer biomarkers. So the current theory of prostate cancer metastasis holds as such that some of the tumor cells from the primary prostate cancer can go under epithelial mesenchymal transition and enter into the blood system or lymphatic system. So these cells are called circulating tumor cells. Then some of those cells will arrive at the bone and stay there for quite a while. And those cells in the bone marrow, we call them disseminated tumor cells. And our study focus is on these disseminated tumor cells. And later on, these tumor cells, actually DTCs, they are generally detected very early on in prostate cancer patients. Greater than 65% of the patients can be detected with DTC prior to radical prostatectomy. And these cells can stay there for a very long time, and they're resistant to radiation and chemotherapy, so they have the potential for later metastasis, actually. So yeah, exactly, when sometimes they serve, like they are there kind of acting as seed for later metastasis. So sometimes when whatever triggers the microenvironment or the immune system whatever, the triggers the change might trigger the change of mesenchymal to epithelial transition again. And so those cells will go back and seed at a distant site and become metastatic cancer. So we are interested in characterize those DTCs partly because these can serve as really good biomarkers, as we know that the prostate cancer biopsy success rate is really low. Even with CT-guided biopsy, the success rate is only 60 to 70%. So bone marrow actually provides an opportunity for repeated testing. And also, we're thinking these DTC cells might predict the future metastasis in high risk versus low risk. So we started off trying to use look at these very rare DTC cells. Typically, you can isolate only 2 to 20 cells from these prostate cancer patients and look at the genetic profile using genomic array methods, and to correlate the profiles of these DTCs to patients' matched primary tumor, their clinical characteristics and disease outcome, to define genomic alterations associated with progression. We would also like to compare the genomic profiles of the DTC isolated from patients with localized or advanced and metastatic lethal prostate cancer to define the molecular evolution of DTCs during prostate cancer. And the way we extract these DTCs were from using the bone marrow, and then they go through first Fico gradient centrifugation to isolate mononucleated cells, and then they go through a series of negative and positive selections to get rid of the blood cells, leukocytes, and then finally we will stain them with epithelial-specific markers. So in this case, and along with blood cell markers, so you will have the red stains for the CD45 positive blood cells, and whereas the green stains for the epithelial markers representing the disseminated tumor cells of prostate origin. So then we usually end up with just a 2 to 25, these cells, and then they go through whole genome amplification. So we extensively validated these approaches using different kinds of whole genome amplification methods, and decided on the optimum one that we chose to use is the Rubicon Picoplex system. And then we compare them with the primary tumor or METs, which are laser captured, and then run on the Illumina Cytoscan SNP array 12. And this is a lower density array. However, for these cells, whole genome amplified, we found that lower density array actually worked out better. So I won't go through the details. And here's the representative genomic profile of primary cancer and the DTCs from that same patient at the time of radical prostatectomy. So you will see the primary tumor shows focal abnormalities, focal deletions here and there, but the DTC cells look pretty clean over there. And here's a representative genomic profile for a metastatic sample along with the DTC obtained from the patient. And so you can see there are so many different abnormalities in the lymph node metastasis, and which in the DTC, although it's lower resolution, they pretty much match very well. So we went through the validation process on the look at the using RTP quantitative PCR method to validate those gains and losses detected by the laser captured whole genome amplified approach of genomic profiling in both the laser captured as well as the DTC cells. And so these actually they have validated very well. So here's a summary of all the samples that we've tested so far. So here's a summary image of this is a normal control, normal prostate and liver control from patients. So you just see some common copy number variations. Then early stage DTCs, you see very little events. Advanced stage DTCs, you see a lot more events and very much similar to those of the metastatic samples. And whereas primary tumors, you also see some of the focal abnormalities that are common. And so if you look at these bottom 3 panels, you'll be able to see there are some common regions shared among DTCs and primary tumors and metastatic tumors, whereas other regions are relatively distinct in each group. And so we looked at how we classify them as private versus common variations, etc. So the bottom line is that copy number events that are large, and especially in the late stage advanced DTCs and advanced disorders, and those are most likely private events, whereas the smaller events, they're most likely copy number variations that are common in the population. So as mentioned earlier, for early, when you compare the DTCs with matched primary tumor, there's very little commonality there actually. The highest percentage of overlapping is in the teens percentage, whereas the similarity between DTCs and metastatic tumors are very much similar. So this is from one patient. We had multiple metastatic sites and looking at the genomic profiling obtained from these samples. And you can see many commonalities as well as differences. So from this part of the talk, we have concluded that it's still just a preliminary conclusion that DTCs from early prostate cancer are characterized by limited focal aberrations, which are heterogeneous within and between individuals, and genomic profiles of an individual's DTCs frequently diverge from their primary tumor, suggesting that both the DTCs and the primary tumor undergo evolution following the dissemination. We think the genomic profiles of DTC from patients with lethal metastatic cancer are generally clonal and highly similar to their metastasis, further lending the support to the model that DTC serves as seed for metastasis. So we also identified regions of recurrent abnormalities in these metastatic tumors and the DTCs. So with this, I would like to thank my crew at the SCCA Cytogenetics. This is part of the crew participating in the pink glove dance. If you haven't seen it, go online and look for SCCA pink glove dance competition video. A lot of fun. This is really I am very lucky to have this group of cytogenetics technologists who know how to have fun and to work very hard. So vote for SCCA. And this is my research lab. And with, I mentioned Jamie Shamborn is the one who did most of the prostate cancer work. This is actually, she just found a job at the Gates Foundation. And here's Xiaoyu Chu, who worked on AML. And another postdoc recently, you will join the laboratory. And this is our wonderful administrative assistant, Meg Bender. And I also want to thank many of my collaborators at Hutch and UW Hematopathology and UW Urology as well. So first of all, I want to specifically mention Scott McElhone, who's the tech who does most of the clinical array testing. Several other people help him out as backups, et cetera, and data analysis. And everybody in SCCA Cytogenetics Laboratory has been just terrific and working hard. And Harvey Greisman at UW provided the mantle cell lymphoma sample that I showed you earlier, and Jonathan Fromm provided with the some other lymphoma samples, and Brentwood has helped us with flow sorting samples. And especially, I want to acknowledge Dr. Applebaum. Without his support, we would not have been able to do any of those. So, yeah, thank you very much for coming here. I'll be happy to entertain questions.
Thank you, Min. That was an excellent talk. Let me ask a question first, and then if you just repeat the question for people out there in TV land, that'd be great.
Okay, I'll repeat the questions.
My question for you is, with next generation sequencing coming along very rapidly, how is that going to impact this kind of work here? Is it going to completely replace it, or is it just an adjunct in addition?
So the question is a fantastic one, and Dan just asked with the next generation sequencing coming up in a rapid pace, how is that going to impact this testing? So I think we have a window of opportunity right now because this is already here and today, and it is useful, and the technique is already very mature and clean. Whereas next generation sequencing, it's still not whole genome at the moment. Right now, most of the next generation sequencing platforms is targeting a subset of the genome, and I know Colin and Dr. John here is they're already doing a lot of those work in targeted analysis. And I think over time, next generation sequencing will replace this technology. But at this time, we still have the window of opportunity to help clinically.
Colin?
Yes, Colin.
This is a great talk. So,
thank you.
I have a question about copy number neutral loss of heterozygosity. It's something I don't know that much about. How frequently are you seeing that in AML cases?
So as I mentioned, in general, you will see it in about 20% of the cases. Oh, the question, sorry, yeah. Thank you for the reminder. So basically, how frequent do we see copy-neutral LOH in AML cases? So pretty much it's in 20% of the cases, and in patients with normal karyotype, normal cytogenetics, we showed in 25% of the patients we see copy-neutral loss of heterozygosity. So this is quite frequent and shouldn't be ignored. And copy-neutral LOH is specifically important in neoplasia because this is the mechanism, one of the important mechanisms for the two-hit hypothesis, for the second hit, how it happens. Yeah. Yes. Yes.
I've always thought it curious that the term copy-neutral loss of heterozygosity gained such acceptance when it's really just isodisomy, which is simpler to think about. So was there some consensus statement, or I mean, why did that term, why is it used such prevalence when instead of just saying isodisomy?
Okay, the question is, in this doctor's mind, the copy-neutral LOH is equivalent to isodisomy. Why is copy-neutral LOH getting such acceptance and used so much more frequently than isodisomy? The answer is the copy-neutral LOH can refer to segmental regions of the chromosomes and not necessarily always the whole chromosome. So so when you're talking about the whole chromosome, then that's isodisomy, that's true. But oftentimes it's not a whole arm or a whole chromosome. So you will have different sizes of a chromosome, like megabasing region. Our cutoff is like 10 megabases and larger, but you can have 20 megabases or 40, or the whole arm, or the whole chromosome. So it varies. That's why it's more accurate to use copy-neutral loss of heterozygosity.
But there are published cases of segmental isodisomy, called disomy. It's just because isodisomy was first used for whole chromosome that is the preferred term?
Well, so personally, I prefer copy-neutral LOH because it is kind of molecularly, it reflects the molecular events that's happening. Whereas when you talk about isodisomy, it's more of at the lower resolution chromosomal level feeling. Yeah, but I think it's personal preference.
Mark?
Okay, yes. Yes.
Along those same lines, have you ever found in small regions where you think someone has inherited pieces of chromosome identical by descent from ancestors, where you have non-pathogenic copy-neutral loss of heterozygosity? Have you ever seen that, or do you think you would see it?
Yes, the question is, have we ever seen actually a copy-neutral LOH in patients, normal patients, non-pathogenic? Yeah. By descent in inherited form of the copy-neutral LOH. Definitely, it happens a lot, and especially in people with consanguinity. And so we've seen that a lot, and it has been reported, etc. And so that's why I also mentioned it's very important to distinguish what's acquired clonal abnormality related to cancer and what is constitutional alterations that's not pathogenic, and those could be very large as well. You're welcome. Yes.
My question was about benign prostatic hyperplasia, BPH, which of course precedes prostate cancer. How often do you see these kinds of loss of heterozygosity in benign conditions, either related to inflammation or benign hyperplasia?
Okay, so this question is regarding benign hyperplasia and inflammation, and how often do we see clonal abnormalities as such detected by the array, in those cases in relationship to actual cancer and neoplasia. And this is a wonderful question. I think the answer varies depending on the specific disease. So we know in breast cancer, even phenotypically normal regions adjacent to clear neoplastic regions, and even without hyperplasia, they often see similar genomic abnormalities detected. However, in prostate cancer, that's not necessarily the case. And I think a few other type of solid cancers that we looked at also show variations and heterogeneity. So there is no one answer that'll address the specific question, but I think it's a very interesting and very important question, and that tells you the different etiology of different cancer types.
So I think we're going to have to stop there because Ben actually has a plane to catch in an hour and a half. So
Yeah.
It's up to Chicago, but anyways, thank you very much.
Thank you.
Thank you.